There we go. Just in case something happens with my internet. Nick, are you able to see the slideshow? Okay, great. Will you let me know if at any point you can't see the slideshow?
Yeah.
Cool. You might have to hit the admit button when people join us, by the way. Hopefully, is it letting you do that as co-host?
Mm-hmm.
Perfect. Hi, Abrima. Welcome. We're going to give it just a few more minutes to see if we have any other attendees joining us. Hi, Paul. Welcome. Thanks for joining us. We're going to give it just another minute or two and see if anyone else hops on. Thank you to everyone who's here. All right, Nick, what do you think? Should we just go ahead and get started and people will join in as they come?
Yeah, I think that's okay.
Okay. Well, hi, everyone. My name is Jess Pelletier. I am the African Medical Coordinator for Techies Without Borders. We run the continuing medical education on stick initiative. We're eventually changing that name. It's still going to be CMES, but it's going to be Continuing Medical Education Solutions, which I think better describes what we do. I am an emergency medicine physician in the United States. I'm an assistant program director for the residency program at University of Missouri Columbia, and I help co-run this journal club each month with my friend Nick Maxwell, who is another one of our volunteers. Nick, I'll let you introduce yourself.
Hi, I'm Nick. I'm one of the chief emergency medicine residents at Washington University in St. Louis, Missouri, in the United States. And next year I'll be doing a medical education fellowship where I get specialty training in how to educate in the healthcare field. And I serve as the medical education coordinator for Techies Without Borders.
Awesome. Thanks, Nick. And this is meant to be an interactive session, so we definitely want people to chime in. You can either write in the chat or you can answer questions out loud as we go along. This is intended to be a learning session for all healthcare workers, and our goal is to do bi-directional knowledge sharing. So we learn things from you, you learn things from us, and we all make progress in our care of patients. So to start us off, we are going to do some cases and then a background, literature review of the article I sent out. We'll talk about guidelines in respective countries, and then we'll do a wrap up. So we already did some welcomes here. Let's start with our first case. You have a 5-year-old male who presents to the emergency department, so accident and emergency, after falling from a balcony that's about 2 meters high. He has not had any vomiting and denies a severe headache. On his examination, he has a Glasgow Coma scale, a GCS of 15, meaning that his mental status is normal, and he has no signs of basilar skull fracture, like raccoon eyes or bruising behind the ears, so vital signs. What is the next best step in management? Feel free to chime in on the chat or out loud what you would do with this patient. Yeah, thank you, Nick, for defining that for us.
I
Okay, so
wasn't
we're
sure
going to
how
go
prevalent
through.
raccoons are.
That's true. I didn't even think about that. It may not be a universal term. So with this child, we often use something called the PCARN, or the Pediatric Head Injury and Trauma Algorithm, to help determine who needs to get their head imaged. And this child is older than 2. They don't have any altered mentation or signs of basilar skull fracture, but they do have a high risk mechanism of injury. So they fell from more than 1.5 meters, or 5 feet here in the US. And so the PCARN algorithm recommends observation over imaging depending on provider comfort, because there's only a 0.9% risk of clinically important traumatic brain injury. And we'll get into what clinically important means based on the PCARN study in a little bit here. But essentially, the PCARN rules recommend that you observe this child rather than imaging them, because we don't want to excessively image children and expose them to unnecessary radiation and potentially induce childhood cancer or cancer later in life. I just wanted you to see the difference of, if we clicked no for all 3 questions, then the risk of a clinically important a traumatic brain injury is less than 0.05%. So extremely low. They don't even need to be observed or anything. That person can just go home. And when we say observed, that practice is going to vary depending on where you work. I typically observe children for about 4 hours in the emergency department if they fall into that previous category, the category of PCARN recommends observation over imaging. And what I'm watching for during that time, oh, apparently my slides are not cycling, and I just heard that from Dr. Nick. So let me try again.
There you
Give me
go.
1 second.
No, they are.
Can you see my, okay.
I see the PCARN, like with a
Okay.
click through over 2 and
All right. So this is what our child had. And I was trying to contrast it with, if you clicked no for both questions, then this child would not need any observation at all. And just going back to the first slide here, if we look at how our child falls, um, so when they say observation, usually I'm observing for about 4 hours to make sure that someone doesn't become altered. They don't start having delayed vomiting. They don't start having abnormal neurologic exam findings. So things like weakness, numbness, tingling, can't walk, can't talk, can't swallow. They start having one pupil that's larger than the other, those kinds of things. Okay, so we're going to move on to case 2 at this point. Your second case is a 3-year-old male presenting to accident and emergency from the site of a car accident. He was the backseat passenger and was restrained in a booster seat when the vehicle rear-ended another car at low speed. His parent denies the patient vomiting or having a severe headache. And on exam, his GCS is 15, meaning he has no altered mentation. There are no signs of basilar skull fracture for this patient either. So what is the next best step in management? I would love to hear from one of our attendees. If anyone has thoughts, feel free to chime in the chat or out loud what you would do with this patient. Do you think that they need imaging of their head or not? All right. So ultimately, the PCARN recommends that this person does not even need an observation period. So they're over 3 years old, or sorry, they're over 2. They are 3 years old. They do not have any signs of basilar skull fracture or altered mentation. There was no high risk mechanism of injury and no red flag features such as a loss of consciousness or a history of vomiting or severe headache. There's nothing wrong with observing this patient, but honestly, they can go home from accident and emergency because this patient is at very low risk of something serious inside their brain going on. We'll move to case 3, so a slightly younger child. This is a 1-year-old female coming to accident and emergency after her mother accidentally dropped her directly on her head. This is one of those cases too where I'm sure Dr. Nick and I get a little nervous of, is there non-accidental trauma happening here? Was the child actually dropped accidentally? And so I might want to get some collateral information from other family members if there were any witnesses there to make sure that this was not an intentional inflicted injury upon the child. According to her mom, she lost consciousness for about 6 seconds, but she's been acting normally since that time. And on exam, she has normal mentation and she has no signs of basilar skull fracture, but she does have an occipital hematoma. Welcome, Rebecca. And for anyone who just joined, we're going through some cases on pediatric head injury. Feel free to chime in out loud or in the chat if you have thoughts on what you would like to do with this patient. Do you think she needs imaging of her head, and why or why not? And apologies for any background noise. We are getting our floors worked on in our new house today. So there are some folks here working on our floors. Hopefully they won't be hammering in the next hour. Yeah, I agree with you, Ruth. This kid needs imaging. And does anyone want to take a stab at, what are the high risk features for this patient? What aspects of her history make us nervous and make us think she probably needs imaging of her head? Yeah, occipital hematoma. Great job, Ruth. All right. So in terms of what PCARN would recommend, this child is very small. She's less than 2, so they're a higher risk group. They have a less hard head than someone who's older. And then she does not have a GCS of less than 14. She doesn't have a palpable skull fracture or signs of altered mentation, but there are several red flag aspects to her mechanism of injury. So she was dropped from more than 3 feet, more than 0.9 meters. Yep, directly on her head, Ruth. And then she also has an occipital hematoma, which is concerning. And there was a history of loss of consciousness more than 5 seconds. She's acting normally, but there's enough red flags here that this kid definitely needs her head imaged. All right. So moving on, I just wanted you to see for contrast, if we had clicked yes to item 2, which is the GCS less than 14, palpable skull fracture, or signs of altered mental status, that's also high risk. So that's a 4.4% risk of clinically important traumatic brain injury. So that's a very high risk, super concerning. Thankfully, none of the children that we talked about here had a yes for question 2, but just keep in mind that that is a very scary question. Okay, so let's do a little bit of background. In terms of epidemiology, traumatic brain injury is a leading cause of disability and death around the world. So anywhere from 47 to 280 per 100,000 children. So this is something that many of us will see every shift that we work in accident and emergency. Male children are higher risk. As with all traumas, men tend to be at higher risk than women, and that starts all the way back in childhood. Some of this just has to do with boys tend to be more rambunctious and be more engaged in very physical activities. Perhaps women have more fears about doing high risk things. It's hard to really know for certain where that comes from, but clearly this distribution or difference in risk for trauma happens very early in life and continues throughout life. There's a bimodal distribution, meaning that young children and teenagers are higher risk. So obviously little kids, they fall all the time when they're running around. And then teenagers tend to start engaging in high risk behaviors. So maybe they're driving cars or motorcycles without helmets or without seatbelts, or they are jumping off of high things because their frontal lobe's not fully developed and they don't think about the risks or consequences of those things. So the children in the middle group, kind of school age children, are a little safer. About 80% of traumatic brain injuries are mild, meaning that they'll have a Glasgow Coma scale of 13 or more. And less than 10% need surgical intervention, but that's still somewhere around 1 in 10 kids that may end up needing something done to manage their TBI. Pedestrian or versus motor vehicle collision is more common in lower resource settings. So in our setting here in a high income country, we usually see victims of motor vehicle accidents who are in the vehicle themselves. So it's car versus car, as opposed to pedestrian versus car being a more common mechanism of injury somewhere like Africa. In terms of the pathophysiology, we'll only be covering closed head injuries today. So a focal injury refers to an injury to one part of the brain, but really it is multifocal. So the coup is, if you guys have ever heard of coup contra coup is a direct impact or blow that then causes compromised blood supply directly at that site. and your brain will actually rock around inside of your skull. So you get what's called a contractile injury on the opposite side of the head. And so you can get contusions or intraparenchymal hemorrhages or other injuries on the opposite side of the brain. Apologies for the background noise, and let me know if you have any trouble hearing me, and I can start writing things in the chat. Diffuse injury refers to something like diffuse axonal injury or shearing, meaning that there is damage from an extremely high velocity trauma. The brain has been shook around so much at such a fast speed that you have injury everywhere. Secondary brain injury, meaning on the cellular level, can occur hours to years after a closed head injury. We won't be covering penetrating head injuries today. That's a whole different ballgame, and it's not something that we would ever consider not imaging. So those people who have penetrating head injuries, here in the States, usually gunshot wounds, but in other places, it might be something else. Those children all need to have their head imaged with CT. So serious brain injuries that we'll kind of talk about today include diffuse axonal injury, cerebral contusions. We'll talk about multiple types of intracranial hemorrhages as well. So all of these pictures are, for the most part, in adults. It is very hard to find open access images of child traumatic brain injury online because it is so rare for children to have brain bleeds compared with adults. So I do apologize that these are adult heads, but the findings look the same in kids. They just have smaller heads than adults do. So this is a normal brain. And for context, we're looking at an axial cut, which means that we are cutting through this way. So the person's feet are coming toward you in the picture and their head is far away from you. So it's like they're laying down on a table and you chop their head this way. So where my mouse cursor is, Dr. Nick, can you see my mouse cursor? Yeah. Okay, so where my mouse cursor is, that's anterior, that's posterior. This is right over here. And this is left over here. These are the ventricles. We're taking a slice through the brain where the ventricles just don't happen to be very big. But you can see that there's nice differentiation between the gray and white matter, meaning that you can see that this section is darker, this section is lighter, and this is the way a brain is supposed to look. It looks like a happy, healthy brain. This is diffuse axonal injury, and I think you guys can appreciate that there's less spaces between the sulci and gyri because there's swelling in this head. So you just don't see as much black area. You don't see as much open space because everything is crowded together. And then there's less defined borders between the dark and the light parts of the brain on the image. It just looks like a ball of mush. This child had a cerebral contusion. Notice that the front part of the brain doesn't look too bad, but if you look back here at the occipital area, you can see that there's a bruise in this kid's brain. So these two areas that have dark areas and then lighter ones inside of them, these are brain bruises or cerebral contusions. This is an unfortunate situation. This is an epidural hematoma, and these typically occur due to damage to the middle meningeal artery, which lies outside of the actual space where the brain is. The problem here is that that blood collects and it shoves the brain over. And I think you guys can appreciate that the midline, which is this white line here, is not really in the middle anymore. It's getting smushed over and it's compressing this ventricle, which is problematic. And if this situation is not resolved surgically, this person will ultimately herniate, meaning that their brain will travel to where there is more open space to allow for decompression of pressure. And that usually means down. It means going toward the spinal canal. And when someone has herniated, their outcomes are absolutely terrible and often fatal. This is someone with a subdural hematoma. I picked this image because I think we always think of subdural hematomas as being on the lateral aspects of the brain, but they can also happen in the subfalcine space. So they can happen in the middle of the head where you normally see that midline. If you don't see a single fine white line as the middle marker of the brain, there's clearly something wrong, and this is blood collecting. And I think you can appreciate the difference between the epidural, which is this really clear lens shape. It looks almost like a contact lens and has well-defined edges because it's outside of the brain space, and the meninges are fixed to the bone. And so essentially the meninges prevent this from going any further beyond its bounds other than continuing to push this way, as opposed to a subdural hematoma, which is below the dura. And that means that it can smush the brain however it wants because there is no connection to the bone that is holding it in place. This is another example of a subdural hematoma. Ignore this side. There's other things going on here, but this person has an area that's lighter on the lateral aspect of the head on the right here. So I think you can appreciate these are blood products that are pushing over the brain. There's not a lot of midline shift yet. This still looks okay, but you are getting kind of smushing of the parenchyma, which is the brain tissue. And realize that, see how this edge is not clearly defined and it's not lens shaped? And that's because this blood is collecting underneath the dura, the wrapper around the brain. And so it's able to push directly on the brain tissue itself. This is an example of a traumatic subarachnoid hemorrhage. This person has other things going on. There's a big hematoma over here that's partially visible in the image. But essentially you can see there's a star-shaped pattern of whiteness, and you don't see all 5 points of the star, but often you will get a circle of bright blood here, and then you'll get arms of a star here, here, and here. I think you can see a little bit of an arm right there, and this arm and this arm are pretty prominent. And so this is blood in the subarachnoid space. And if it occurs in an atraumatic fashion, this is usually due to rupture of a berry aneurysm, but this patient's had a traumatic subarachnoid hemorrhage. This is a devastating injury. So this is an intraparenchymal hemorrhage. All of that white stuff you see is blood, and it is pushing over the midline. So this is the midline of the brain, and it's even compressed this ventricle on the patient's left side completely, and it's starting to infringe on the ventricle of the right side of the brain. By the way, please do let me know in the chat if I'm speaking too quickly. I'm trying to modify my speaking speed. I know I talk very fast and I have an accent, so apologies if I'm hard to understand at any point. This is an intraventricular hemorrhage. So the ventricles are supposed to be black, and you can see that there is white blood in the ventricles of this patient. And this is a surgical emergency. Generally, neurosurgery will need to drain that blood out of the ventricles using some sort of shunt device, because those blood products can coagulate, and then they can prevent reabsorption of cerebrospinal fluid by the little cells that line those ventricles. And that becomes problematic because it blocks outflow of CSF and then leads to increased intracranial pressure and eventually can cause herniation. Okay, so we've gone through some basic types of traumatic brain injuries that are clinically important. We're talking about the clinical presentation of a TBI. Often these people will come in with altered mentation, altered mental status, or loss of consciousness. They may have focal neurologic deficits, but sometimes these can just be global because of how severe the damage is. For example, in that case that we looked at right here, this person would probably have global deficits. So I'm sure that they would be very altered and possibly unconscious. And you may not be able to tell if they have focal deficits or not. Signs of brain herniation can include bradycardia, hypertension, and a unilateral dilated pupil. One thing we need to realize, though, is that only a small percentage of people will show up with all of those symptoms. So it's very rare to have the triad of all 3 signs and symptoms of herniation, that hypertension, bradycardia, and unilateral dilated pupil situation. Loss of consciousness and posturing are also possible with herniation. So just sort of a quick reminder on what posturing is. This is decorticate posturing, and this is decerebrate posturing. And these usually progress from decorticate to decerebrate, and they indicate that there is compression of the brainstem and that someone is herniating or that they have a bleed in the brainstem. Okay, let me know if you have any questions about the background that we just discussed. We're going to move on to a literature review of the PECARN study, which I sent out in the CMES group chat. So we'll talk about this article. The methods for this study, so they looked at children at 25 US emergency departments. They ended up recruiting about 42,000 kids. So that's a lot of people. They were all children less than 18, and they did a derivation cohort, meaning the group of people they looked at to figure out a rule that would allow them to determine who's at high risk for a clinically important TBI. Then they created their rule based on some fancy statistics, and the validation cohort was recruited in 2006. The inclusion criteria was presenting within 24 hours of head trauma, and the exclusion criteria included trivial mechanisms. So if you just like tripped and hit your head on the door, or you just bumped your head on something minor. If someone had penetrating trauma, so again, we're not going to get into that today. If someone had baseline problems with their brain, so they have brain tumors or they have a known neurologic disorder that would cause them to have weird looking head imaging. In terms of their definitions, What they considered clinically important TBI was death from TBI. I would agree. So is definitely clinically important. Neurosurgery. Remember, less than 10% of kids who have a TBI will undergo a neurosurgical intervention. Intubation for more than 24 hours for TBI. So that's something that's not even accessible at all of our hospitals. So that's definitely clinically important. And then a hospital admission for 2 or more nights due to a TBI. I would love to hear, please feel free to speak out loud or chime in the chat. Are there any other criteria that you would consider to be clinically important TBI? I think they hit the nail on the head here, but I always like to hear if other people have different thoughts. All right. So what they defined as a TBI on CT were a lot of the horrible head injuries that we already went through in terms of imaging. So cerebral edema, so brain swelling, diastasis of the skull, if they saw a diffuse axonal injury, if there was a brain bleed, if there was midline shift or a cerebral contusion, if they had signs of herniation on CT, which is very bad, if there was air inside of the intracranial cavity, pneumocephalus, which usually indicates that there's an open fracture of the skull, if there's a shearing injury, so that's similar to diffuse axonal injury. And then sigmoid sinus thrombosis, those can be kind of hard to see without a CT venogram. So I don't know exactly how they quantified seeing those on regular head CTs. And then depressed skull fractures, as well as traumatic infarction. So if someone had an ischemic stroke because of trauma to their brain. Their study aim was to identify children at very low risk of a clinically important TBI for whom a CT was unnecessary. And they had large number of patients. So there were over 8,000 kids less than 2 for the derivation population and 25,000 kids older than 2. About 35% got a CT scan, and they found clinically important TBI in less than 1%. Only 0.1% of those children ended up having neurosurgery. They then did a bunch of fancy statistics and math that I'm not going to get into today, but they identified what were considered to be high-risk features in that derivation population who ended up having clinically important TBI on CT. And in the validation population, they then determine what the sensitivity, specificity, all that for their clinical decision rule looked like. And so they had over 2,000 kids less than 2 and over 6,000 kids greater than 2 in the validation population. In terms of their results, the sensitivity for the PCARN head injury rule was 100% and almost 100% for the older kids. So it was 100% for little people with a negative predictive value of 100% for both groups. And neither rule missed neurosurgery in validation populations, meaning that there was nobody who was put in a low risk bucket who later went on to have a brain surgery. So that's encouraging. Limitations here are that they didn't CT all the kids because that would not be ethical. You obviously can't scan thousands of kids and give them all cancer if they don't actually need a CT. And then the CT rate in this network was less than the US national average because the PCARN network consists of emergency departments or accident and emergency units that are what are called level 1 trauma centers. So these are big name hospitals that see lots and lots of kids, very high volume. And so they have very standardized guidelines and rules already about who should and shouldn't get a head CT. And so if you present to a community hospital in the middle of nowhere in the United States, so in a very rural area, you might be at higher risk for getting a CT than a child who presents to one of these PCARN fancy hospitals. And then they didn't look at long-term outcomes, meaning they didn't follow up on these children a year, 5 years, 10 years later to see how they were doing. Can anyone else think of additional limitations of the PCARN study? Obviously, a big one is that this was at US level 1 trauma centers, right? So it didn't occur in a community hospital setting, and they didn't have any centers outside of the United States. So practice patterns may vary. Accessibility of imaging may vary greatly in other places. I'd love to hear from people out loud or in the chat whether this practice, the PCARN rule, is being used at your own facility, or if you use something else to help you determine who needs a head CT. Very quiet group today. All right, so we'll go through guidelines fairly quickly. This is all that's in the Uganda clinical guidelines. Oh, thank you, Ruth. You use PCARN and ACRA as well. And Ruth, I assume since you're an EM resident, you're at a big trauma center as well. So it's probably quite similar to where we practice here at our centers in St. Louis and in Columbia, respectively. I would love to hear from someone who's in a more rural setting. So who's in a community hospital, what you typically use to determine whether a child should get head imaging. And if you even have head imaging at your site, do they have to get referred to a bigger hospital so that they can get imaging? Oh, thanks, Dixon. So not using it at Malago. These are the Uganda clinical guidelines. So early CT if available, and they say severe traumatic head injury, but they don't define what that means. So there's no definition in there for what a severe traumatic injury is. And so that kind of leaves it up to provider discretion as to whether a CT is indicated or not. We won't get into open head injuries, but they do mention giving antibiotics if you have an open head injury. And then they talk about prevention. The Gambian guidelines actually don't have any discussion of traumatic disorders. So I know there are several Gambians here on the call. If anyone has thoughts on, how you practice in your own setting, perhaps a BRIMA, I'd love to hear what the head imaging strategy is for children with head injuries in the Gambia. All right, I'm actually going to paste the survey link in the chat. It's been a little quiet today, but I appreciate you guys coming, and we would love for you to fill out the post-session survey to let us know what you learned and if these sessions are useful for you. In terms of our take-home points, traumatic brain injury can have serious consequences, and these are not just in the immediate setting. They lead to a lot of morbidity and mortality down the road. And using a clinical decision rule can help make it easier to make your imaging decisions. You have to take these imaging decision rules like PCARN with a grain of salt and figure out if you think they would apply to your setting or not. However, using the PCARN rule can be helpful. I think Nick's laughing because there's hammering in the background. So these are my references. And again, this is the QR code for our survey today. I'm going to mute here. And if anyone has questions, please chime in the chat or any thoughts that you want to add before we close up for the afternoon. We'll give it just another minute here to see if anybody wants to chime in about the practice patterns at their sites. And if not, I think we'll wrap up a little early this afternoon, but I appreciate everyone chiming in and being here. All right. Thanks, guys. Have a good rest of your day.